Uh, what do you think about culture, the culture of your ER? And oh, by the way, every ER I've been in has its own unique culture. And have you heard the saying, you've seen one ER, you've seen one ER? That really is true. They are culturally very different places. Let me give you an example. I was working with an ER. We had a very ambitious change package that actually worked quite well. As we were working through it, we had to change the physician's schedule by 1 hour. One shift a day, moved back by 1 hour. Their culture, unbeknownst to me until we got to this point, was very, very conservative. They were very change averse. Things had to take a long time to happen. And we were signing the charter for the project, and the doctors refused to sign the charter and made a personal statement about that, okay? That had not happened to me before. I believe it was in large part because I did not understand their culture. I did not understand how they worked through change and so forth. Fast forward, a different hospital, same size, similar issues. We're getting ready to make some changes. We made 19 changes to the schedule for the physicians. 19. Not a single complaint. Their culture was quite different. The medical director had the trust of his other doctors. They looked at the data and said, we're going to move these shifts around, and so they did. Where would you fall, by the way, in terms of your culture when it comes to change? That's something I want you to be asking yourselves. All right, so ED culture, can you change it? There's a guy, Max Cohen, who is a change consultant. He writes a lot for Harvard Business Review. He says you change culture through process improvement. What do you think? Do you think that's possible? Could you change a culture by making some improvements and sort of stepwise? Could you change the culture? Let me tell you a story. Okay, hold on. Ay. Forget it, a little seizure in my remote here. So what is culture in healthcare? It's really hard to define, isn't it? We're going to go through that, and then I've got a tale of 2 ERs that I want to show you that were so different, and that's going to lead into just a phenomenal success story where we show you how some changes came about. All right, so what is culture in healthcare? It's this nebulous, sort of vague thing. You know it when you see it. It's like pornography, right? Culture's like pornography. You know it when you see it. How about this? Like the air we breathe, it's individual and collective, right? It influences our attitudes, our values, our beliefs, and then it translates into behavior. And I will tell you what, I've been in ERs all across the country, and I've seen very different behaviors that are a result of the different cultures of that particular place. Healthcare culture is very conservative. Would anyone disagree with that? How long does it take to get a change, even an evidence-based change, from the realization to the widespread implementation? How long? Yeah, a decade. We're not turning on a dime here in healthcare, are we? We're not turning on a dime. But you know what? I'll say one thing in defense of the conservative nature of medicine. There was a drug in the 60s that was used widely in Europe. It helped people to stop vomiting in the first trimester. And then we realized, too late for the epidemic, that it caused limb deformities. The young people in the room, do you know about thalidomide? Thalidomide babies. We did not know that that drug, which suppressed the nausea and vomiting, caused babies to be born with terrible limb deformities. They literally were born with flippers. Instead of, the US had the lowest manifestation of this. Why? Because we were more conservative than everybody else by a long shot, and we just didn't jump on board with the new bandwagon. So there's something to be said about a conservative culture. It may not be serving us now, however, at least from an operations standpoint, when change is afoot in medicine and change is afoot in society. It's also hierarchical. Okay, who's higher on the totem pole? The transport tech or the medic in your ER? Who's higher? The medic. Okay, who's higher on your medical staff? The family practitioner or the cardiothoracic surgeon? Anybody? Surgeon, right. Where is that written down? Is it in your bylaws? Do your job descriptions in your ER say, oh, transport tech, you're lower on the totem pole? No, we understand it though, it's implied, and healthcare is extremely hierarchical, right? You know this. I always say there's like this secret handshake. Specialists want to talk to each other. It's a very hierarchical, almost militaristic in that way culture. It's just important that we sort of understand ourselves and how we operate. So can we change culture? A tale of two emergency departments. And I'm not making these up, and this was an aha experience because I actually was working with both at the same time. So, very busy departments, seeing about 300 patients a day. Anybody seen 300 patients a day or more? I think we have a couple of you. These are the super ERs, the very big ERs. They each were about the same size, 100 beds. It's kind of like a small city, isn't it? 100-bed ER, right? They had ample staffing, they had ample resources. Whoops. This is the waiting room of Hospital A. I wheeled a wheelchair for the picture because I thought, how else will you know this is an ED waiting room? And I don't mind bragging for them. This is Texas Harris Health in Fort Worth. They see 120,000 visits a year. That's their waiting room late afternoon. Now look, to be fair, it's very new. It was about 2 years old at this picture. This is another ER. We're going to call it Hospital B until we tell the whole story, the expose. Actually, most ERs I've been in look a little more like this than like this. How about you? Yeah, okay. But I'll tell you what, my first exposure to this ER, there were 59 people in the late afternoon in the waiting room. 59. And there was kind of a disconnect of what was going on in the back with the fact that there were 59 people in the waiting room. Misery quotient very high. Somebody's vomiting in a garbage can. Somebody felt faint, so she's just laying on the floor, right? You got Frankenstein with bloody bandages walking across the room like this, right? Anybody getting the picture here, right? So very, very different, right? Hospital A, they did so many quirky things, and I'm going to tell you about some of them when we talk about scheduling. They just did some things that were very quirky, didn't seem to make sense, and how they would explain it to me, this is what kept coming up. Better for the patient. Well, we do it that way because it's better for the patient, including the way that they staffed, the way they flowed patients, and so forth. Hospital B, as many ERs, when they are struggling, what happens? Have you ever heard the blame game, right? Doctors thought it was the nurses thought it was docs, somebody thought it was the techs, everybody, you know what I mean. So this was a very difficult time. And mind you, I'm seeing the Hospital B in a time of crisis. And the people I'm talking about are in the room, and like I say, we'll spill the beans because the story's remarkable. This was Hospital A. Looks like it was a touched-up photograph. It's not. I took that with my little cell phone camera. That's their ER. Can you kind of even tell? I know it's not a moving picture, but everything's kind of organized, kind of quiet. There were almost 90 patients in that ER at that moment. Didn't have a sense of it, just kind of quiet. Everything's going along smoothly. I'm going to poke a little fun here. Can anyone see, this is a workspace in Hospital B, the alcohol wipes sitting on the paper shredder next to the space heater? And does anyone think that's a problem? So, and mind, can I show it? Like I say, this is actually closer to the ERs that I've worked in for 30 years. We noticed on the bulletin boards some memos that were more than 2 years old. Now see there's a brown box next to the space heater. There was a Wendy's cup that was there for 2 more visits when I came, an empty Wendy's cup, okay? Are you just getting kind of a little sense of what's normal for each place? Let me show you this. They had just had a major trauma. This hospital has everything that you would dream of for your ER, by the way. They have an observatory above their trauma suite so that you can look down. Anybody been in this ER that I'm talking about, Texas Harris Health, the new one? Sidebar, this is the most unique set of circumstances I could ever conjure up for an ER. The medical director, Dr. Jesbray, has been there for 40 years. His nursing director's been there for 30 years. They are very good friends. They work really well together. They have a guy in the ER that's intensely interested in operational improvement. And so for literally, imagine 3 decades straight, the mantra of that ER is, how can we make it better? How can we do it better? They have suggestion boxes everywhere, and they're constantly changing and improving, and they work well together. The teamwork is just, you sort of feel it, and what they've told me is that someone that doesn't fit into their culture does not stay. They kind of, you might not want to stay here, you don't fit in. It was a very civil, the most polite ER I've ever been in. Everyone was terribly polite, and they said, well, if a surgical resident comes down and wants to have a bad day down here, we tell them no. No, we don't do that here. We don't talk like that, and we care about the patient first and foremost. It's really an amazing place, and it's worth a field trip. All right, now, and I'm poking fun here. Mind you, I do have to tell you that Hospital B has very good metrics for sick patients. They have great trauma statistics, they have great sepsis statistics, and so forth. But I kept going back to this room. There had been a resuscitation. Oh, by the way, there's space for like 12 resuscitations at once. This person had been resuscitated. I kept going back. This is like 4 hours later. Anybody note the urinal laying on its side with TT in it, that's a medical term, TT, on top of a chest tube tray. And I just kept going, well, when are they going to clean their house? When are you going to clean your room here, your bedroom? No one seemed to think that this was unusual for it to sit in this. Anyways, notice doors open, paper on the floor, blah, 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 right? Trauma resuscitations are messy. It's a team sport, and it's messy, by golly, and you got to clean your room after. Let me show you their staffing, okay? So patients per day, Hospital A and Hospital B. They're both very, very busy ERs. Look at the physician and APP staffing for Hospital A versus Hospital B. Don't you think that's really astonishing, okay? Look at your nurse staffing. Look at the tech and clerical. Jim talked to us and explained to us about it. Look at that. If you're used to the work hours per unit of service, 2.8 for this kind of a hospital that's this busy with this kind of metrics, this is amazing that they're doing so much with so little. And I want to say, I have seen, in fact, currently right now, I'm sort of attached to and involved with 2 ERs. One has a WOPUS of 2.3. Do I have my Washington Hospital people here? Amazing. 2.3, they are staffing. They see 3 patients an hour. Their metrics are fantastic, and I actually wonder why they've invited me to come visit, but I'm going. I'm excited to go. 2.3, I have another one, and I will not name them. They're at 4.1. What is this about? Look at the differences. You've seen it in their housekeeping, in how they staff. Now look at the metrics. So here we started, and oh, by the way, Hospital A, I hear from Dr. Jesbury now and again, they're up consistently to about 400 patients a day, and their door-to-doc, they've teased it down to 17 minutes. And look at that. Length of stay overall, under 3 hours. You're admitted under 4 hours. Are you kidding me? This is amazing, especially, this is tertiary teaching hospital affiliated with Parkland. This is really, it's stunning. And their walkaways, 1%. This is really, really great performance. Hospital B, when we started, we were having trouble, right? We were having trouble. The wait times were very long. Look at there, you're admitted, you're 7 hours. 7 hours if you're going to be admitted to our hospital. Just count on it. That's the average. So there's where we were. What do you think explains these things? It's culture, isn't it? It's culture, that nebulous thing that we're having a hard time defining. It's culture that makes certain things normal, certain behaviors normal, certain expectations normal. And I want to suggest to you that each of you has your own culture. I'm going to ask you again, are you more like Hospital A or more like Hospital B? Moment of truth here. Culture is very locally defined, and that's what we saw here. So, can I say who you guys are? Anderson Emergency Center, Rhode Island Hospital. First of all, this has got to be the most clever name on the planet. They are Anderson Emergency Center. They've been around for 10 years when they said, we are going to re-engineer ourselves. We are going to improve ourselves. We're going to fix ourselves, all right? And so they called themselves AEC 2.0. That was the name of the initiative, which I think was wildly, wildly clever. This is from their charter, and I think it's very ambitious, and I respect it totally. Transform the way we deliver care to meet the needs and exceed the expectations of our patients. Do you like that? I mean, you could kind of get up in the morning and get behind that, because remember, change is hard, isn't it? It's hard work. You may think it's easy. It is not. It's hard. And this is what they got up in the morning and said that they were going to do. Very interesting, too, how sometimes the most ambitious change package brings people together, because now we're all working on it together to try to make these improvements. There's my blow-up slide. I told you, you got 1,000,001 uses for this slide. If you want it, I will send it to you. But they truly did blow up the way that they did their workflow, patient flow, all of the processes. They built from the ground up how they wanted to flow their patients through the department. They built it, retrofitted it into the space that they had, and then fixed the staffing to support it. Okay, and that's, by the way, I believe how you should do your projects. The other thing I wanted to say is this is kind of a new mindset. Hadn't you learned before process improvement, you make a change, you rapid cycle test it, you see what happens, right? One little step. I want to say something I think is even more effective and that you should consider. Why not do what they did, blow it up and start over? And because most of you are flowing because it just kind of happened over the last 15, 20 years. You're doing things the way you're doing it because it just sort of happened. It wasn't by design. I would want to suggest to you, how about designing it? How about doing it by design? So this was their flow model. It's kind of similar to what you saw earlier. I said, I want you to have a flow model. I don't care what it looks like. It's yours to design. But I want you to use data to decide how you will flow your patients through the department. This is an ER that has 40% of their patients come by ambulance. 40. I'm telling the truth, right? 40%. I don't know what's going on in Rhode Island, but there you have it. You cannot bed 40% of your patients as soon as they arrive. You'd like to bed the sickest of them. And so what they did is they said, doesn't matter which door you come by, we will assign you very quickly an ESI score, and we will decide where you go. And they sent the sick patients right back to the beds. Almost everybody else went through a physician in triage, which they did not have. They sent their fast track straight over to the fast track, those very low acuity things. Boom. Now we're moving patients quickly. So their change package involved a lot of things. Guess what? They had done away with their fast track. They brought it back. They didn't have provider in triage. They had to reinstitute this, create this where they hadn't had it before. They decided to do vertical flow. How many people are doing a mid-track with vertical flow? Yeah. I hope most of you are pleased with how it's going. It's a very efficient way. Not everybody needs to get naked in a bed, because you know what happens when they get naked in a bed. Then they're, nurse. Every 5 minutes, Mr. Wilson, you drove here. Why are you, in bed with your gown open in the back? Huh? And then they had a very important goal, which is they wanted to immediately bed the sick ambulance patients or the sick ambulatory patients. So the ESI2s, get them in a bed. Anybody putting ESI2s in the waiting room? Are you forced to ever? There are places that have to do it. I know that ENA does not like it, doesn't approve, but sometimes it just you're between a rock and a hard place. Their goal was they didn't want to do that anymore. So physician in triage. And as I mentioned to you, and I will say it again, there's so many ways you could cook this goose. There's so many ways you could do this. You can do it from the quick look, seeing 112 patients a day, physician triage, to you see about 35 or 40, and you do half of the workup. So you would decide what would work for you in your place. The vertical model, they brought in these lounge chairs from all over the hospital in the beginning. I thought that was actually pretty smart. Said to anybody, can we have your lounge chairs? Oh, by the way, oncology almost always has lounge chairs that they're turning over because they're always getting new ones. It's a good place to go. You can try labor and delivery too. Take those and see, does this work? Can you make the model work? It worked so well, then they got a bunch of brand new chairs. And and I think that was a clever way to go. So rooms became vertical flow spaces. The fast track, which had been, sort of a mirage, on some days some doctors would try to do a fast track. Now they resourced it. In particular, everything is in a very nice space where it's got good proximity. They even have their own waiting room for the fast track. How many of you would think this? You've only got 5 beds for a fast track. I'm going to tell you, make one room a waiting room for the fast track. What do you think? Mark me, you will move them faster, because now you can control in your fast track who's in the bed, somebody who needs a treatment or a diagnosis, who's in the chair. Yeah, honestly, you will optimize your fast track by giving up a bed, and I know it's almost counterintuitive. In any case, they had 6 beds, they resourced it, and some days this rocks. What's the record you've seen in your fast track? Isn't it 59 one day? Something like that. Dennis, the guy with the red tie, he's the data guy, so he knows. He's nodding there, he's validating, yeah. All right, if someone wants to build you this is an ambulance offload area. Just say no. Why do I say that? Anybody ever had a space where your ambulances could come in and we're like, oh, well, great, we'll have a space for ambulances to offload. Do you know what happens in every place that I've been in contact with that's had one is wanted to get rid of it? I'm always looking at ways that I can block it off and not use it, because it just becomes a parking lot. Now it's a parking lot for ESI2s on gurneys. So just say no. But look at this. There's nobody waiting there. Because as they went live with all of those complementary changes, all of a sudden, they were able to get ambulances back into the ER in front of a doctor quicker. So here's their data. I think this should knock your socks off because this is a real live success story. So, yeah.
Was there a difference in salary between those 2 hospitals that they paid their nurses, or?
Differences in salaries. Gosh, you got me. I never looked into that. Now, I will say one thing. Unionized nursing at Hospital B, not at Hospital A, but I don't know. I'm sorry, I can't speak to that. Right, the hospital that was so efficient didn't have nurse unions, but they did at the other one. And I know that's hard. Any of you here have nurses that are unionized? It's hard. It is just hard. I'm sorry. It's just I feel like it splits the allegiances, and we forget that we're trying to do the same thing for each other. It becomes very adversarial in a lot of places. I don't know if it is at yours, but anyway, here's what I want you to know. So door-to-doc time's down to 23 minutes. And I can be a voyeur and watch their progress, and they're still holding more than a year out. Okay? Left without being seen dropped down to under 2% because people aren't having to wait, right? You understand that? But look, we didn't even touch the admit length of stay. Shaved about 40 minutes off of that. Median length of stay, shaved an hour off of that. So can you imagine how different that would be? And I'll tell you what, so I know I started out and I was kind of busting their chops with my first impression of how they were. So remember I told you, my first exposure, there they are in the waiting room, 59 patients, okay? I've been back since, and here's what I see. Most of the time, unless they're boarding, right? We can't control boarding. Empty waiting room, 6 o'clock in the evening, empty waiting room. And I will hear a nurse, if somebody does come and wait, a nurse say to another nurse, oh, that guy's been waiting for 20 minutes. I didn't hear that on my first visit. So what I'm saying, my question to you is, can you change culture? And it's a continuous journey, but anyway, I think we ought to give them a hand because I think this has been amazing improvement, yeah? And it was a pleasure to work with them. I still have a couple of minutes. Dave and Susan, will you guys come up here? I want to have them answer some of these questions, okay? Because another thing I wanted to point out, that ER is so big, there were literally 500 people that had to come along with the change. So what's your question?
As far as switching from patient care areas where you had beds to the vertical patient care areas, how did you get around the regs for space? So many feet between.
So we kind of
Ignored them?
ignored the regs to some extent, and we kind of, in our way, we sort of tell people, if anyone asks us, that this is really a results waiting area. The patients who go to that vertical care area have their labs drawn in triage, their walk to plain film x-rays if they need them on the way there, and then they're really waiting for results. In reality, they do get meds back there from the nurses, and they'll see the advanced practice providers, but no one's point blank asked us that, but that's our prepared answer. And quite honestly, it's just safer than having people in the waiting room, so you can't really argue with that.
Yeah.
We don't have patients in the hallways. We don't.
Yeah, we don't do hallway beds.
With patients in the vertical areas, when you go back to reassess them after their workup is complete, where do you go for privacy to do a reassessment, and who moves them?
So the physician, if patients go to the vertical area, if I'm the triage physician, I've seen them. I've done their whole H&P, and I've laid out a plan, and I have a scribe who's writing all that down for me. I leave explicit instructions for our APPs who receive them, look at all their results, follow my plan, and if they talk to the patient, they use their discretion. So if they're going to tell someone they have an STD, they bring them out of the room and into another room. We have one room that we have like a procedure room. If it's like, hey, you have a bronchitis or your asthma acted up, we're probably going to tell that in that room where there might be another patient. But if they have insurance information, registration, might pull them into the hallway or something like that.
What's interesting is they often become good friends. You're so worried about privacy, and they don't even want to leave each other. Oh, can I have your phone number? So we've certainly seen that.
I mean,
And
the bottom
actually-
line is in the hospital, there are shared rooms. I mean, HIPAA there's supposed to be some, semblance of, you don't have to, doesn't have to be completely private, but you have to make some efforts towards privacy.
Yeah.
What do you do with your waiting rooms when you have the families that arrive with 9 people, a minimum of 2? They wait in the waiting room and bring everybody back?
I mean, those rooms get tight. When you have two recliners in a room, one family member is easy, 2 family members starts getting a little heavy. And so we just ask them to rotate in and out.
So your PIT documents up front with the scribe, and then you hand off the case to your APP?
Yes.
Do they dictate or scribe?
So they'll just do a little update note. Patient's labs came back, everything looks normal, or the patient has a kidney stone, they're going to go home.
What's the communication process between you and that APP? How do you do that?
So we're logistically separated by about 30 yards, which is kind of a big space. We have phones, but quite honestly, so these are the patients we're selecting, and we like to think of them as very focused. And so there's usually a clinical question like, you have the kidney stone or you have appendicitis. So I don't really care which one it is. As long as they have one of those things, the APP doesn't even need to talk to me again. If the
Yeah.
patient has appendicitis, they get admitted. I don't really care. I'll find out at the end of my shift when I sign all my charts.
They did something clever too with Epic. They have what's called the sticky note in Epic, where you can just write notes that are not part of the record. And so he can communicate if he would like to. I really think this is Pilo, just leave a little note. Some of them use that, some not. But you're right, communication, you've always got to think this through when there's a handoff.
But you have to have good APPs as well. And our APPs will come to us. If they say, this doesn't smell right, or I found out some other information, did you know this? And they'll communicate with us when it's not so focused, when it gets more complicated. Go ahead. Throughput? So what's your hospital throughput like? So I'm not sure how to answer that question. So our median length of stay in the hospital is 5.2 days. That's gone up a little bit lately because we have some throughput issues in our OR. So I'm not sure what it is the last 2 months or so, but that's what they tell us.
So you have no problems getting your patients when they're admitted up?
It takes about, from the time we put the admit order in until the patient leaves the ER, probably a median time is about 100, 110 minutes. So on a good day, it might be 70. On a bad day, we're up at 150. From the time everyone agrees they should be admitted. So.
So the ESI 2 is direct pad, and you do the 3s like kidney stones, bronchitis, gallbladder, that kind of stuff.
Right. So we all know there's 3s and there's 3s. So, the 75-year-old lady who has right upper quadrant pain might not be able to sit in a recliner chair. So we'll choose in triage, like, this patient can't go to vertical care. They're too sick. They need to go to a more comfortable, resource-rich area. They need to lie in a stretcher. So that's what the physician in triage is doing. They're figuring that out.
What were your biggest successes in terms of
I'll let you take that one.
And oh, by the way, remember, she's trying to lead 500 people. Many of them are a unionized workforce that was not so happy when we started. So this was huge.
So one thing you really have to realize is their work environment was really poor to begin with. So they knew that, they were unsatisfied, and so a lot of these changes as we laid it out where we were, right? When you go through change, you want to talk about the burning platform of what's burning. Well, we were burning pretty much, coming in and coming out, and our staff was unhappy. So once we gave them exactly where we were, the comparison data to our other like places like us, and exactly what's different about us and exactly what's not different, because a lot of our staff says, well, we're different. We're different here. We're different. We're not that different from everyone else. So I think those were some of the things that brought. But this communication strategies, showing physician and nursing leadership alignment was very important because we had some work to do on that. So those kind of things were very important. And once we rapid cycle changed it, we did 1 or 2 days, if you remember, and then after that, they're like, can we do it again? Why are we going back to the old model? What are we doing? Because their work environment was so different. We didn't have patients pounding on the triage window asking when they could come back or getting worse or those kind of things. So, yeah, so once they saw that, but then that oversight kicks in because everyone wants to, go back a little bit to what they were doing. But there was a large force in communication and the oversight through that. So it was a long process for that. We're still going through that.
All right, they're waving at me from the back. We want to make some
happy
closing
to
comments.
talk any more afterwards. But I think that, to your point, comparative data, a lot of communication, giving people the opportunity to see our presentation, see what our plans are, ask questions, emails, posters. And so no one could say when we went live, like, hey, I didn't know this was going on, And then also we told people, we apologized up front. We said, you know what, something's not going to work. The plans are written in pencil, and we'll change them if it doesn't work. And I think that took the air out of the balloon for some people.
Yeah, you want to hear one of the coolest? They had an app that you could see on the phone that told about the project. So you could look at it on the way into work. So that's pretty clever.